Welcome, everybody, to another session, Cases from the Community. Investigators discuss the optimal management of EGFR-mutated non-small cell lung cancer. I'm Dr. Jacob Sands, thoracic medical oncologist from Dana-Farber in Boston. Very excited to join you all and have an opportunity to moderate what are going to be some really exciting discussions, exciting talks to see, and a lot to discuss now in EGFR-mutated non-small cell lung cancer. We'll go through, well, first of all, let me start with introducing the faculty. We have Dr. Antonio Passaro from the Division of Thoracic Oncology at the European Institute of Oncology in Milan, Dr. Joel Neal, Professor of Medicine, Division of Oncology at Stanford, Dr. Jonathan Goldman, a Professor of Medicine and Thoracic Medical Oncologist at UCLA, and Dr. Sarah Goldberg, Chief of Thoracic Oncology from the Yale Cancer Center. We'll go quickly through some of the disclosures to see, these are mine, and disclosures of research to practice team. Here's the commercial support for today. Research to Practice CME Planning Committee. Staff and reviewers have no COIs to disclose. This program will contain discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product for applicable indications. So in order to make this meeting more relevant to attendees, Dr. Love interviewed 3 general medical oncologists, Drs. Susmitha Apuri, Stephen Fred Divers, and Priya Rudolph, who posed cases and queries on a number of key clinical issues. Video excerpts from those interviews will be featured throughout today's program, and we'll offer some topics for further discussion. This is where we're headed today. Professor Passaro will begin with first-line therapy. Dr. Neal will discuss EGFR-targeted therapies for relapsed disease. I'll cover TROP2-targeted ADCs. Dr. Goldman will discuss potential role of bispecific antibodies, and Dr. Goldberg will cover some of the toxicity and tolerability considerations. And with that, we will start with our first lecture by Dr. Antonio Passaro.
Thank you very much for the kind introduction, and it's a great pleasure for me to be here this evening with all of you and discussing the first blocks of the presentation, so the evolving first-line treatment for metastatic EGFR-mutant non-small cell lung cancer patient. So I think that at the present time, discussing new data, discussing the evolving stage with a phase 3 trial that moved from monotherapy combination is very, very important, but it's important also to characterize better the patient characteristics, patient with EGFR-mutant alterations. So we know at the present time that the patient carrying EGFR alteration, common EGFR alteration, are characterized by different kind of high-risk feature. And we know that brain metastasis, liver metastasis as a clinical high-risk feature, or P53 co-mutation of elevated baseline ctDNA positive are some of those high-risk features that characterize limited survival. But I think it's very, very important when we try to focus on a patient that receive osimertinib in clinical setting, to focus that very limited number of patients, limited rate, achieve a very long-term survival. In this real-world analysis of more than 1,000 patients that we publish in JTO, we can see that the 5-year survival rate is around 80%, and the 3-year survival rate is around 41%. So this is a very important number when you try to contextualize the results and when you try to understand the impact of the osimertinib first line. Another dramatic number is generally 25-40% of patients in the clinical setting candidate to receive osimertinib generally do not receive a second-line treatment. And of course, there are many, many kind of explanation, but today, not all these kind of analyses are very, very well understanding. So we know that generally we have a significant benefit with the OSI, but generally we have no long-term benefit. And the median is not so high compared to the progression-free survival benefit. But the most important point for the limited efficacy of monotherapy, not only with osimertinib, is very low number of patients with a long-term benefit. So today we discuss around data with lorlatinib, but this is completely another story. So we have less than 10% of patients, according to data published with 5 years survival rate. And the topic of today is very, very important, not only to discuss the new part of the evolution, the combination of FLAURA2 and Mariposa, the two main phase 3 trials approved by FDA and EMA, also Europe, but also to open a future evaluation for the future of the combination. So all the phase 3 trials at the present time ongoing or ready to start are evaluating as a new harm the combination of ADC plus osimertinib. So the future is more oriented to combination, waiting for some new kind of TKI available in the first line more than osimertinib. And this first analysis, this is progression-free survival Kaplan-Meier curve of the FLAURA2 study. The FLAURA2 was a randomized phase 3 trial comparing chemo plus osi versus osimertinib monotherapy. We can see that the benefit in this trial is very, very consistent for all the flow. So with an hazard ratio 0.62, but a benefit around 8 months. So of course, this is a very important standpoint for patients with EGFR-Mutant alteration. And we can see that the benefit is consistent over the time. And after 2 years, 24 months of analysis, we have a 16% of difference in favor of the combination. But as anticipated before, we know that there are some patients characterized by limited benefit with osimertinib monotherapy. And this analysis of high-risk feature, we can see that globally, the impact of the combination with the osi plus chemo was consistent across more or less all the subgroups. In patients with or without brain metastasis, in patients with liver metastasis, and also patients with a different kind of a molecular subset. For patients with a T53 commutation, there is no significant difference according to the PFS, but there is a benefit in the hazard ratio according to the long-term evaluation. Important point was the presentation of the overall survival. The overall survival were presented during the World Lung Cancer Congress last year. And you can see that globally the trend is very, very consistent in favor of the combination with a median OS of 47.5 versus 37.6, so the real median of the FLAURA study. There are some criticism here in this slide. We can see that there is an important crossing of the curves in the first 12 months of treatment, but then we have a significant benefit over the time in favor of the combination. And an important point for the FLAURA2 is the progression-free survival benefit for patients with CNS brain metastases. And we can see that here is a very, very interesting to focus that the addiction of chemotherapy to osimertinib increase the CNS progression-free survival. The hazard ratio is 0.58, and the numerical benefit is around 3 months. This, of course, is an important message, in particular also in the discussion with the other combination that we'll discuss later. And, of course, is an important also measure to translate in the clinical setting where patients with brain metastasis are a significant number when we consider EGFR-Mutant non-small cell lung cancer. In TERSLING, the resistant mechanism analysis performed on the plasma and on the tissue confirmed that more or less the acquired resistant mechanism was broadly similar between chemo-osi and osimertinib monotherapy, considering and including the major secondary resistant mechanism on target, other EGFR mutation, and MET amplification. Of course, we know that the MET amplification generally is evaluated and tested on the tissue, and the liquid is not the best methods. But of course, for this kind of phase 3 trial, performing a tissue biopsy after progression was not mandatory for all patients included. Sarah later will discuss deeply all the safety, but I think it's important not only to discuss a point-by-point the safety analysis, but also to focus on the blue box in the slides. So the median exposure to pemetrexed for patient that was candidate to receive the combination was around 8.3 months. And 50% of patients discontinue pemetrexed for toxicity. Of course, this is an important point to consider in the evaluation, the opportunity to use this kind of combination in the clinical setting. But I think that is very, very useful for all of us to understand that, of course, a short course of chemotherapy could be effective in achieving the overall survival benefit. But in this analysis presented by David Plasha in a poster in the European Lung Cancer Congress, we can see that higher is the exposure to pemetrexed and longer is the survival. So we can see here in the same slide that the patient with a limited exposure to pemetrexed showed a very limited survival compared to those that that receive pemetrexed for more than 18 months. And the difference is impressive, from 13 months to 30 months. So of course it is an important point to contextualize also in a real-world data setting. The second part of the presentation is to discuss the other combination approved by FDA and the combination of amivantamab and lazertinib. Lazertinib is a third-generation TKI, very, very similar to osimertinib, and amivantamab is a bispecific antibody able to interact and inhibit the pathway of MET and EGFR, potentiating the TKI activity. And the combination of amivantamab IV plus lazertinib was evaluated in the Mariposa study and compared versus osimertinib. And we can see here that the hazard ratio for progression-free survival was 0.70, and the median was 23.7 versus 16.6. And globally, these Kaplan-Meier curves support, as discussed also before for FLAURA2, that the combination is really effective in this kind of study. But also in the Mariposa study, we evaluate the efficacy of the combination according to the high-risk subgroups. And also here we report liver, brain, T53, and ctDNA evaluated the baseline. And globally, we can see that the benefit of the combination is the benefit compared to osimertinib is consistent across all the subgroups. But I think that the important message in this slide, as in the previous, is not only that the combination performed better, but for those patients with high-risk groups that are candidates to receive osimono, the median OS is not 18, 19 months as reported in the FLAURA, but it generally is around 1 year, 13 months. And this is a very important evaluation to translate in the clinical setting. The median OS was presented last year at the European Lung Cancer Congress by James Young, and we can see here that the median was not reached at the time of the presentation, with an hazard ratio of 0.75. Also in this trial, as discussed before in the FLAURA2, we have a crossing of curves in the first 9 months, not so marked in the FLAURA2, but of course you can see in the first part that there are some signals there. But a little bit different from the FLAURA2, we can see that the benefit in this Kaplan-Meier curve increase over the time. So after 24 months of analysis, we have 5% of benefit in favor of the Mariposa combination. After 36 months, we have 9%, and after 42 months, we have 12%. So it's a benefit that step by step during the time is increasing in favor of the combination of amivantamab plus lazertinib. Different for the FLAURA2, in the Mariposa, we have a completely different study design and methodology to evaluate the brain efficacy. And here we can see that there is no significant benefit in the first 24 months when we analyze intracranial progression-free survival. In the Mariposa, all patients receive a brain MRI at the time of the baseline and every 8 weeks. But we can see a very important signals that is corroborated also in favor of the overall survival. And we have intracranial progression-free survival benefit that is threefold better for amylases versus osimertinib at 36 months of analysis. The hazard ratio is 0.79. The benefit is consistent with the FLAURA2, is around 3 months. But I think it's very, very important. So this is not only to consider in the clinical setting, but also science behind it, biology, to understand the impact of a double block on EGFR and MET. So for patients that receive amylase in the Mariposa study, we can see that the mechanism of resistance was completely different between combination monotherapy. For patients that receive amivantamab plus lazertinib, we can see that we identify four-fold reduction less for MET amplification, also in this trial evaluating liquid biopsy, and also five-fold reduction of EGFR on-target alteration. So, of course, this is an important message, an important signal, not only for today, but also in particular for the new study with the new ADC for the future, where the disease could be completely different from OSI and AMI plus lazertinib. Same focus here, the safety will be discussed later by Sarah, but I think it's important when we focus on amivantamab to consider that this is a dynamic evaluation. At the time of the presentation, data for amivantamab was confirmed according to amivantamab IV, and now the opportunity is to use amivantamab subcut with the evolution of Paloma, Cocoon, that I think will be discussed deeply later. But according also to the opportunity to improve the patient's feeling with the treatment, we know that interruption is not affecting the survival also here, and the interruption is very, very an important approach to improve the feeling and also to improve safety for patients that develop a high-risk toxicity. And according to the safety, that is a part of the next one of the next presentation, why is important to consider the story of amivantamab as very dynamic? Because from the presentation, the first Mariposa for PFS ESMO 2023, today we have a lot of modification. We have a prophylactic support for VTE, for skin. We modify the infusion from IV to subcut. And now we have, of course, a significant, consistent data that support that toxicity are completely different and reduced during the time using this kind of approach. And now I think we have the first case from the community. Thank you.
All right, so we have a case here from Dr. Divers. Thank you for submitting this case, and we'll hear a discussion with Dr. Love.
Good evening, everyone. In our unique Cases from the Community CME format, we enlist general medical oncologists to meet with me and present real cases from their practices for input from the faculty. Tonight, Dr. Susmitha Apuri, Fred Divers, and Priya Rudolph present cases of EGFR-mutant non-small cell lung cancer, beginning with Dr. Divers, who presents a challenging and common situation. A patient with metastatic non-squamous lung cancer who has an indication for immediate use of chemotherapy before important biomarker information is available. Our surveys of investigators suggest that on occasions, oncologists will consider the smoking status of the patient, but in this case, that led in the wrong direction.
This is an 82-year-old who is a very heavy lifelong smoker, who has the typical associated history of coronary disease and atrial fibrillation. His liquid NGS, which was sent at the same time as his tissue NGS, was actually negative for any actionable mutations. He was very concerned about recurrence of his pleural effusion, and we discussed, should we think about a Pleurex catheter to prevent repeated thoracentesis. He elected to go ahead and begin some therapy because of this concern, rather than waiting on the tissue NGS. So he actually started carboplatin, pemetrexed, and pembrolizumab, and his pleural effusion improved. However, about a week after he got his pembrolizumab, the tissue NGS came back positive for an exon 19 deletion. At that point, we discontinued any further pembrolizumab and continued with his carboplatin and pemetrexed. He was in place on osimertinib and has done well. The question for the faculty would be, in hindsight, maybe I should have just given the carboplatin and pemetrexed alone and then added or subtracted osimertinib or pembrolizumab based on the data. FLAURA2 allows you to at least start with the carbo-pem, and then you can add based on PD-L1 and actionable mutation status. Amy and lazertinib would have been an equally good choice here. What differentiating factors do you see in a patient that would drive you to say, I would choose single agent OC versus OC carbo-pem versus Amy lazertinib?
I love this case. I think this is a great one. There's so much about this to consider. So first of all, for time, I'm going to say, just broadly speaking, I think anybody that we don't have genomics back on that needs to start urgently, I would start chemotherapy alone. Now, I often will talk to patients in a way where that stresses patients out to wait as well, though. So what I often tell patients who aren't symptomatic, but who are just pushing you like, I need this, I'm dying, is to say, look, we have the opportunity right now to figure out what is the best treatment for you instead of starting the first treatment. But if you're having symptoms and we have to go with the first, then we will start chemotherapy urgently. I want to focus the discussion a bit more, though, on which regimen to start. So let's say in this, well, before I do that, starting chemotherapy broadly, and that this is a great highlight for that, anything anyone wants to add to that, or are we all in agreement? Agreement.
Agree.
All right. So now jumping to how to manage. So let's say you have the diagnosis from the start, and now has not gotten any treatment so far. What would be your preferred regimen, and what's driving your decision making? Go ahead, Dr. Goldberg.
You ask it like it's an easy question.
It's so simple to say.
So I think the easy answer to me is most patients should be getting combination therapy. Like, gone are the days that patients are getting osimertinib monotherapy, unless we think there's tolerability concerns with the different combination regimens. So I think a combination regimen is appropriate for most patients. You just saw all of the data. 2 trials, both with PFS and OS benefit compared to osimertinib alone. So a combination regimen. I didn't answer your question about which one.
Yeah, I'm going to press you on that.
So again, you just saw the data. Both regimens have benefit. And actually, to me, they're very similar in terms of efficacy. The toxicity, which I'll talk about later on, is really where there's the differentiating features. And then it just really depends on the patient and their kidney function, where maybe you can't give chemo, or they don't want to get a rash. It's really important to them, so then you wouldn't want to use amivantamab. So I think they're both really reasonable, and I'm happy to use either one. In practice, I probably use more Fluoro-2.
There we go.
Because I knew you wanted me to answer that.
But
I had to give the background. I'm sorry. It's important. Both are really reasonable, and I use both on a regular basis.
So your preference, it sounds like, though, is chemo and OSI, but certainly not osimertinib alone. That was clear. All right.
I give the long answer.
Yeah. Anyone have, for balance, a preference for Amy-Laz in this case?
I think that Amy-Laz at present time is my preferred option. Why? So the first that, of course, we need to discuss with the patient is the possibility to use a subcut and not IV from the beginning, and I think is important. And the second point, also to maintain platinum pemetrexed as a second-line treatment, because this is the only one now today that we can use. But of course, I think it is important, as also discussed by Sarah, to discuss with the patient. So the benefit is consistent across between the 2 studies, but the infusion is different, toxicity are different, GI versus cutaneous. So I think it's very, very important to discuss, but it's not to de-intensify the standard, but to try to intensify the standard for all patients.
All right, so what I'm hearing from both of you is a preference for combination, a leaning toward Fluoro-2 here, a leaning toward Amy-Laz there. How about you guys? What would be what's your general preferred first line, and what's driving your decision making in this?
Yeah, having been in practice from well before osimertinib was even the preferred first-line drug in EGFR-mutant lung cancer, it was a very easy drug to use. So I've been in the habit of generally, when I see an EGFR mutation, prescribing osimertinib, then talking about chemotherapy, Fluoro-2 lends itself to that sort of approach. Also, I'd say up until recently, Amy-Laz has been kind of hard to use. Intravenous infusions, infusion-related reactions, 2 days in a row of 8 hours, trying to schedule in our infusion room is nearly impossible, plus the weekly time after that. I think that's changing. And I still don't know exactly which patient Amy-Laz is better for compared to the Fluoro-2 regimen, but I think they are both quite compelling, and osimertinib by itself is no longer adequate for most patients.
Yeah, okay. Anything you'd like to add?
I would agree with all of that. I think I do get concerned about the long-term derm toxicity of amivantamab, lazertinib, and there are some patients that are reported to have that kind of peter out over time, but that's not always the case, and so I think that can be a cumulative, challenging toxicity.
So how about uncommon EGFR mutations? And it's so hard to get through so much data in so little time. So there are more slides, and please go download the slides, and you can see those. There are some slides on uncommon EGFR mutations. But how, Dr. Passaro, how is that impacting your decision-making for when you see uncommon EGFR mutations? What regimens are you typically starting with?
Yeah, I think the first point to analyze better the kind of uncommon, PAC, typical, because we know that all these kind of alteration perform in a different way when we treat with the treatments. At the present time, we have a lot of experience with osimertinib that was not officially approved or tested here, but we have a lot of real-world data. And the only drug that was approved by FDA was afatinib, but with a very limited kind of numbers in the LUX-Lung story. So generally, here the feeling is more in favor of osimertinib, but I think that the data that were presented today by John of amylase are very impressive in the setting. So we have a significant OS benefit of 14 months. That is an important number. Of course, this is not a randomized study. It's the limit of this kind of data. But I think is corroborated the story of the efficacy of amivantamab across the different kind of alteration. ECONS 20, common and also uncommon.
Okay.
Yeah, if I could add a little bit, I mean, we did share interesting data today. So uncommon mutations, we can think about the exon 20s. Those are different. Amivantamab and chemo is approved in my first line preference because sunvozertinib, where we saw good data against chemotherapy today, is not approved yet. I mean, it was approved, but it's not available yet. So it's hard to use, but it is a compelling first-line option. I think they could be used sequentially. When we think about the other atypical EGFR mutations, as we call them, Elliott 61Q, I think you can get away with osimertinib, FLAURA2, any of those usual regimens, because it's a classical-like mutation. But if we look at the really PAC-like mutations, I think that's where osimertinib doesn't do a very good job, and probably lazertinib by itself doesn't either. Our AMI-LAZ data showed a much longer PFS of that combination compared to about the 9 months you see with OC and 41-month overall survival. Interestingly, ASCO guidelines 3 days ago were updated to add afatinib, osimertinib, and AMI-LAZ all as first-line options for atypical EGFR-mutant lung cancer.
Excellent. All right, and so with that, we will go to the second case discussion.
In every corner of oncology, new agents and regimens are being approved, resulting in promising opportunities but also challenges for patients and clinicians. First-line treatment of metastatic EGFR-mutant non-small cell lung cancer is an excellent example of this phenomenon, where the basic platform of a third-generation EGFR TKI has been combined with either chemotherapy or a bispecific antibody, resulting in greater efficacy, but also posing the common oncology dilemma of having to indirectly compare the risks and benefits of these two combination approaches. This particular situation is complicated by the fact that while there's a depth of experience with chemotherapy, clinicians have far less experience with the EGFR-MET bispecific antibody amivantamab, including the quality of life impact of the recently available subcutaneous formulation. Dr. Apuri recently encountered this challenge in caring for a 79-year-old woman with an EGFR exon 19 deleted pulmonary adenocarcinoma. This patient was previously treated with adjuvant chemotherapy for breast cancer and had a number of treatment-related complications.
She has been through chemotherapy with her breast cancer, and she was absolutely against receiving any more chemotherapy. So she was initiated on amivantamab with the lazertinib, and there were some dose adjustments that were required, but she did handle it relatively well. She did have a skin rash, but I did do a bit of a dose reduction, and she has done very well. The rash has subsided. I would say now it's a grade 1. She completed 8 cycles. I would like to know how they would sequence the therapies in the metastatic setting for EGFR-positive lung cancer. Who are the patients that they would offer upfront amivantamab with lazertinib? What toxicities that they have seen, and how much of a prophylactic approach they take to prevent these toxicities, and what is the dose reduction that they are willing to offer to the patient.
Yeah, this is great. I do sometimes have patients that come in and just say, no chemotherapy. And it's interesting, amivantamab lazertinib has a real toxicity profile to it. We're going to talk about that. I don't know that carboplatin pemetrexed is so much more difficult. I think in some ways easier. But someone who's gone through breast cancer therapy, that's a lot of toxicity in with the chemo from breast cancer. This is obviously a challenging discussion with patients. No matter how that discussion goes, though, if they say no chemo, then no chemo. So, Dr. Goldberg, I know we're going to get to your discussion on toxicity, but I'm going to let you kick us off again because of the toxicity question here. What is your experience of amivantamab lazertinib toxicity? What kind of pearls can you give us? It sounds like Dr. Aparna did a great job with this and some dose reduction and patient tolerating it well on rash, but that can be challenging. What pearls can you offer us?
So I think the first thing when you use amivantamab in a range, different patients, you see just a range of outcomes. Some patients have very little toxicity. The rash is really not a problem, and other patients have really significant rash. It's like many other treatments we use where there's a range, but it really feels very real in these patients where it goes from minimal to very severe. So I think following your patients closely, as we always do, and really strongly considering dose reductions, dose holds, those are so important. We saw the data about how modifying the dose is not so much of a concern for efficacy, so if that needs to happen, it's fine to do. There are prophylactic approaches that really have helped. I think this combination is very different now than it was when the Mariposa trial first came out, so the toxicity tables from Mariposa are almost not really relevant anymore because now we have prophylactic strategies and other things where we're really able to do better. But still, for some patients, it's still very challenging. And sometimes we need to discontinue the AMI and consider lazertinib alone. But that's similar to with chemotherapy as well. Yeah. So there is a range, and you need to watch these patients closely.
I think it's really important. The Skipper data, the Cocoon data, and then we'll see Copernicus packaging this all together to show us what does the toxicity look like with the updated prophylaxis. I'll tell you, too, just for time's sake, the bottom one there with Paloma 3 showing that not only was the toxicity better and not having the immune infusion reactions when giving sub-Q, but actually looks like maybe some better efficacy when giving subcutaneous as opposed to IV. We'll come back to that if there's time, but I really want to focus for a moment for myself and then for others. When you're giving amivantamab and dose reductions, what is your... I've heard of some individuals who are treating and they dose reduce a bit more aggressively and patients tolerate so much better. So what is your line for these dose reductions or holding that you would do, that you're doing differently than, for example, what happened within the protocol?
I think one of the points I always think about is the timing of toxicity. If it comes on very quickly, I think you're headed in a tough direction. And so I think taking a little break, if in that first month you really have, headed towards grade 2, even, significant grade 2 toxicity, that could be a time to take a little moment, make sure that the patient's taking all the prophylactic antibiotics and topicals, and then restarting at a dose reduction.
Well, grade 2 is what happened in the trial, too. Are there any individuals in which, it sounds like if it's happening, like if you start and it's grade 1, but it's coming on right away, are there people where you're like, let's just hold for a moment? Or
yeah, exactly. I think at that point, there's a lot of enthusiasm and motivation on the patient's standpoint, but I've found that if they have toxicity in the first couple of weeks, you need to get ahead of it. And so I encourage them that we're in this for a marathon, not for the sprint, and we're going to manage the toxicity appropriately.
Anyone else? How are you dosing?
I think what's interesting, so we have a lot of experience with IV, AMI, and AMI-LAZ, and sub-Q AMI and AMI-LAZ. I have less experience in the frontline setting. We had a couple of patients in that. But I wonder, with the subcutaneous dosing, if we can think about other dosing strategies too. Instead of weekly dosing for the first 4 weeks and then going to every 4-week dosing, do we need to really load in the first month when we're seeing progression-free survival curves that don't separate at all for 9 months? Is it okay to get to steady state at month 2 or month 3? I've heard of other investigators or other treating physicians who are even starting at dose -1, with the subcutaneous and coming in like that. But we're nervous, right? Because we have overall survival data with one dosing strategy, and we don't want to compromise the efficacy. On the other hand, we want our patients to have a good quality of life and be able to tolerate their therapy.
Yeah, that's why I ask about it. I think there are some individuals that report a very good experience for their patients, and I think they're more aggressively dose reducing, dose holding. Maybe it is the early grade 1s then, because grade 2s you'd hold anyway. Dr. Passaro, are you doing any kind of dose adjustments beyond what the protocol showed? Any early dose holds or dose reductions?
Yeah, generally, in my experience, I try to start with the standard dosing, particularly with the subcut. But I think the idea is to consider it as a chronic treatment during the time, so we do not need a grade 3 to reduce the dose, but also a consistent and long-term grade 2 is one of the key to reduce the dose, in particular because, as discussed by John, we are considering the overall survival, and this is the key for this kind of patient. But at the present time, with the subcut plus Kikunes skipper is a completely other story in the toxicity flow compared to IV. And it seems like two different drugs, in particular for those patients that are on treatment for more than 1 year and a half.
I certainly celebrate the subcutaneous dosing and no longer having the infusion reactions. Certainly much more to discuss on the management for amivantamab, and Dr. Goldberg will get to that. Right now, we'll go to Dr. Neal, who will speak about EGFR-targeted therapeutic strategies for relapsed EGFR-mutant non-small cell lung cancer.
Thank you, Jacob. If we thought first-line treatment of EGFR was complicated, the next couple of talks, we're going to really get below the surface and think about resistance mechanisms that we're causing. Ideally, these treatments work forever, but as Antonio shared, unfortunately, they don't. And resistance mechanisms are complicated, and we're finding new strategies to overcome them. There you go. Okay. So these are the things that we'll cover. And then in the next couple of sessions, we're going to cover other strategies to overcome resistance and maybe new first-line treatments. So we touched on this in the first talk, but basically you can have on-target resistance. One of the most common mutations is the C797S mutation, which prevents the direct binding of the third-generation TKIs to that irreversible binding site. We can see other EGFR mutations that also cause TKI resistance. EGFR amplification can happen at the same time, just, more gene causing more protein to cause a mass effect of activation. Classically, MET amplification, first described in 2005, like 21 years ago, as a mechanism of acquired resistance to the first-gen TKIs, still happening. And this is a bypass tract where you're getting signaling around EGFR. So to battle it, you have to not only inhibit the original EGFR mutation and signaling, but also MET at the exact same time. Then we can see other oncogenes coming up from subpopulations, ALK, RET, BRAF, we've seen these before, cell cycle gene alterations, MAP kinase pathway alterations, histological transformation. I think small cell was reported early. Squamous cell transformation, as we do more repeat biopsies, is being increasingly appreciated also as a mechanism of resistance. And then kind of unknown, we either didn't test in the right way or we don't have the right tools to look and see why is there resistance. So I'm an advocate for both liquid biopsy as well as tissue biopsies to be able to see all of these mechanisms of resistance and do DNA testing, RNA testing, maybe more protein testing, look for everything to see what's going on there. So with that being the case, we do have data in the second-line setting regardless of mechanisms of resistance. One of the trials was the MARIPOSA-2 study, so we've talked a lot about amivantamab in the classic IV dosing plus lazertinib plus chemotherapy in the MARIPOSA-2. And there were arms also of chemotherapy and then ami plus chemotherapy. And when we look here, progression-free survival, 6.3 months in this previously treated population, it didn't look like there was an additional contribution of lazertinib to this, which surprised me a little bit, that AMI chemo clearly beat chemo, but adding laser and maintaining that didn't seem to add too much more, and I'm not sure why that is. Overall survival has now been reported, 17.7 months, response rate of 52%. It's pretty good in the second-line setting after acquired resistance to osimertinib, regardless of mechanisms. If we dive a little bit, though, into the mechanisms, you can see some patients, only a handful on each of the arms, had MET amplification over on the left. Looks like progression-free survival was 4.4 months, but response rate's actually a little higher, 67% for the AMI chemo arm. And those who had EGFR secondary mutations, here we expect, amivantamab's kind of acting like a pan-EGFR mutation inhibitor, so it should overcome these. And we do see a PFS that's higher again, 5.7 months and 73% response rate. So a possible way, AMI plus chemo, to battle those acquired resistance on target with EGFR. For AMI chemo, we talked about some of the side effects. I think I'll let Sarah talk more about these side effects in a bit, but these are classically well described, and in the era before we were better at managing the cutaneous toxicities as well as the infusion-related reactions. Then subcutaneous amivantamab came out together with chemotherapy. This was the PALOMA-2 study. All the PALOMA studies use the subcutaneous formulation. That makes it a little easier to remember. I know there's a lot of study names here. I'll focus on a couple of cohorts of this. This is all the cohorts listed, but we'll start off with cohort 3B. Which is a post-osimertinib population, the same as the MARIPOSA-2 study that I just showed you, of amivantamab plus chemotherapy, no lazertinib here because there wasn't an effect before. And what we saw, a 47% response rate, a little bit higher by central review. Progression-free survival, 7.9 months, numerically higher than that, 5 pushing 6 months that we saw in the IV amivantamab plus chemotherapy. And then, adverse events looked like certainly infusion-related, administration now related reactions, because we're not infusing it, we're administrating it. Administration-related reactions lower overall than we would have seen. What about the first-line setting, of Q2 weeks? So I know this wasn't totally my domain, but I said I was asked to cover all the subcutaneous formulations of amivantamab. Here we see a progression-free survival of amivantamab plus lazertinib, 27 months. Remember, we're seeing, first-line of MARIPOSA around 23-plus months. So it looks like, this, at least in a selected population of 68 patients who got a frontline, it's looking like it's performing well here, even in the frontline setting with the subcutaneous formulation. So, thinking about does IV and sub-Q, are these interchangeable from a MARIPOSA first-line perspective? Yes, it looks like they're probably fine. How about Q4 weeks? So this is cohort 5 of the PALOMA-2 study, and Q4 week also had very high response rates in a previously untreated population with first-line EGFR therapy. PALOMA-3 focused on this IV versus sub-Q a little bit more directly. And randomized a couple hundred patients on each side of patients who had disease progression. So this wasn't a first-line MARIPOSA population. This was a second-line post-osimertinib population. 30% response rates, progression-free survival, 6 months versus 4.3 months, maybe underperformed a little bit in the IV formulation here. But the overall survival was actually different between these two arms, and I think that was one of the questions we may get back to after this session is why. Some of the side effects look like the subcutaneous formulation better. Again, Sarah's going to touch on this in more detail probably. All right, so looks like amivantamab plus chemo or amivantamab sub-Q is effective after first-line osimertinib, but we're not really doing first-line osimertinib as much anymore. If we were, though, can we add the chemo later instead of doing the FLAURA2 strategy of like chemo plus osimertinib all at the same time? Can we wait a little bit and add it at progression? And an older study presented by Tony Mock, the IMPRESS study, actually added gefitinib. So gefitinib patients added chemo at progression, and it was worse. The ones who got chemotherapy and continued gefitinib did worse So we were not impressed by the IMPRESS study, and we're a little bit worried that maybe there's something antagonizing about adding chemotherapy later on and continuing the EGFR TKI, as was this study. Actually, that wasn't the case. Fortunately, it looked like continuing the EGFR was not only not harmful, but an improved progression-free survival of 8.4 months versus 4.4 months for just chemotherapy alone. And then overall survival, it looked like there was also a benefit, almost 16 months versus 10. Okay, other kinds of mutations. So what about these on-target mutations, that EGFR C797S? There was a drug, Blue 945. It didn't have full coverage of all the mutations and all combinations. And there was the mix of T790M, which we were still causing by first-generation EGFR TKIs. So Blue 945 had responses, but isn't any longer in development. BH30643, the developmental therapeutic session by Xinning Li is actually going to show a lot of new data for this on Tuesday of ASCO. I don't have access to that yet, but here there are a couple of anecdotes of patients with C797S acquired resistance EGFR mutation, lung cancer, that have tumor responses, and more stories about that on Tuesday. Small cell transformation, other histologic transformation. Well, we've published that carboplatin and etoposide are good. You can give it together with osimertinib if you choose to do. We say that immunotherapy doesn't work so much. Doesn't work a lot in small cell lung cancer either, probably only about 10% of the time. And then we asked, what about tarlatamab, right? And some of these tumors express DLL3, some of them don't. A few institutions got together and showed data. All of these are waterfall plots. None of the patients did exceptionally well with small cell transformation of EGFR-mutant lung cancer, even when we added osimertinib to the tarlatamab, which probably very few people would be bold to do, but there's published data on this if that seems like an appropriate strategy for your patient. But in reality, like, the resistance is not just one thing. Like, it's a lot of things. Like, this is a real diagram that I got from a blood-based test, and here there was the original EGFR mutation. There was an original P53. There's a new P53 at 52%. I don't even know what that's doing for the tumor. There's a BRAF fusion. Like, all this stuff can arise. So you have to think about tumor heterogeneity, and it's not just that tumor A, has resistance mechanism and becomes tumor B. It's splintering into a lot of different types, so we have to think about that. Other strategies, we'll talk about TROP2, the PD-L1 VEGF bispecifics, chemotherapy, OC plus docetaxel, OC-DOCI I like to call it, is an oldie but goodie. The BRAF, I haven't had a lot of success of targeting those things with kinase inhibitors, and there's a whole bunch of ADCs coming down the line, as well as bispecifics, trispecifics, and other things. So exciting times ahead. So in conclusion, EGFR-resistant lung cancer is complex and heterogeneous. You have to appreciate that even if you can't find it on the molecular testing. Looks like subsequent TKIs, chemo, and AMI are all important tools of using here. Repeat biopsy, I continue to advocate for this to try and find targetable forms of resistance, and we'll have a lot more options hopefully in the future. Thank you.
Excellent. So thank you. We'll jump into a case by Dr. Rudolph.
A critical aspect of EGFR-mutant metastatic disease is management of brain metastases, as exemplified by a case from Dr. Rudolph of a 65-year-old man with an exon 19 deletion who presented with generalized musculoskeletal pain, dyspnea, and a 3.5 centimeter primary lung tumor with extensive metastases of the bone, liver, and bilateral brain metastases, which were treated only with systemic therapy.
He was started on treatment with carboplatin, pemetrexed, and osimertinib based upon FLAURA2 trial, and is currently on osimertinib and pemetrexed maintenance. He has had a phenomenal response. He developed complete response after 3 months, including resolution of all brain metastases. One thing I struggle with all these patients with EGFR mutations, especially if they've had prior brain metastases, and also patients that have never had prior brain metastases, is how often do we need to continue monitoring brain MRI? Could we hold off on every 3-month brain imaging while they're on osimertinib? Our patients don't particularly care for MRI imaging. when would you send somebody for SBRT versus resection of an oligometastatic brain metastases? Or do you universally start all these patients on osimertinib because of the excellent intracranial response?
Okay, so a lot of questions here. Let's start out with just how often are you monitoring? So a patient with brain metastases at baseline, starting them on therapy, how often are you monitoring MRI brain? Dr. Goldman, we'll start with you.
Oh, sure. I follow every 3 months for the most part. And as time goes on, I might go to 4 and 6 months. A lot of discussion with the radiation oncologist. I think, it is one of the most exciting parts of fluoride, too. I think is the CNS CR rate is really quite high. My memory is about 50%, which is really quite remarkable. And then there's the challenge of monitoring them, possibly for a year and a half or longer with frequent MRIs. So I think it's in the 3 to 6 month time range.
Okay. And how about just at the start, someone comes in, symptomatic brain mets and EGFR mutation. Are you starting therapy? Is there anyone where you would do something other than just start systemic therapy? Dr. Neal.
I give steroids. No, it depends on why they're symptomatic, right? Is it from edema? Is it leptom? I mean, we've had newly diagnosed patients leptomeningeal carcinomatosis, right?
Yeah.
So you can't treat that with radiation.
Right.
So if it's one symptomatic brain met, sometimes even neurosurgery. Occasionally our patients will get diagnosed with EGFR-mutant lung cancer, and neurosurgeon comes up and I smelled EGFR. I took it out, I sent it off for the testing. Yeah, and this never smoking patient with the right demographics. So I think it depends on why are they symptomatic. But I'm comfortable with both the Fluor-2 regimen and the Mariposa Ami-Laz regimen for CNS penetration.
So I guess what I'm getting at is, because giving the systemic therapy is the easy answer, is there anyone where you would say, we should not start systemic therapy yet, call the neurosurgeon? Or is it hard to come by that kind of scenario?
It's not very common. I think most patients, I'm comfortable giving systemic therapy, and I agree with Joel. I think either of the combination regimens look really good in patients with brain mets. But I think if a patient has a symptomatic lesion, it should probably be treated up front, either with surgery or SRS. No one with EGFR should get whole brain radiation, no matter how many brain mets they have. They are probably going to live for years, and that will be potentially a disaster. But I think a symptomatic lesion, you don't know when you're going to be able to start treatment often. It could take a little while to have a response. So if there's a symptomatic brain met, I don't really see a downside to dealing with it up front.
Okay. Yeah.
But that's the rare patient. Most patients are asymptomatic, and systemic therapy is sufficient.
Yeah. All right, there are some questions here I'm going to try and squeeze in. There was a question about sunvozertinib, that it has a very high rate of diarrhea and 14% grade 3 for exon 20 that can be challenging. Any comments about sunvozertinib and the diarrhea management?
So we just saw the data today. I haven't had a chance to digest it, nor have I used it. I think we've had the occasional patient who's flown to China and gotten it, but not my personal patients, other people in the practice. But grade 3 diarrhea, we've seen that before. We've seen that with TKIs that are approved. We saw that with mobocertinib that got unapproved, which actually looked like it had more diarrhea. And with a lot of prophylactic management, Imodium, the 6 pills a day, sometimes going to Lamodal, you can manage diarrhea sometimes.
Dr. Passaro, I'm going to ask you this one. What's your opinion of the forbidden crossover in Mariposa trial, not allowing crossover?
Why it was forbidden? So Mariposa 2 was presented the same day during the ESMO 2023. So at the time, there were no indication to use amivantamab second line. So this is why amivantamab was denied as a crossover after the first line setting. So only for a timeline approval.
Yeah.
Was that right? You can only use AMI in the first line? So you're not allowed to use it as subsequent therapy?
No.
Oh, interesting. Okay.
Yeah. So any thoughts on implications for management now where they're both available?
Yeah, I think it's a very important question, particularly because also Mariposa 2 after FLAURA2 is not officially supported by the guideline because Mariposa 2 was for patients that was chemo naive. And indeed, we have a very high response rate of 64%. But I think that for those patients that discontinue pemetrexed for a long time, also platinum, this could be an option. But we need to understand the toxicity, the previous toxicity with the chemotherapy. So this is, I think, the point for implication in the clinical setting. Of course, consider the efficacy in first-line setting. I think it is important for patients to identify the covered room, the covered slot to use amivantamab in first and second line, waiting for other opportunity for a clinical setting.
So here's another one. Does lazertinib have the same risk for ILD as osimertinib when exposed to immunotherapy? The second-generation TKI did not have this harm signal.
Yeah, the risk for ILD is very, very low, but is consistent across all the third-generation TKI, not only lazertinib, osimertinib, also almoreltinib is more or less the same, but it's very, very low here. So I think it's not a limitation point for use the third-generation TKI alone in combination.
I mean, we worry about both ILD and there was a lot of transaminitis when you give osimertinib after immunotherapy. I don't know that I've seen data, using lazertinib in the same setting. I don't know of trials that have really explored that, but I wondered that one time in clinic. When I had a patient who had gotten the first dose, just like our first patient here this evening, gotten the first dose, I was wondering, would LAZ actually be a safer option? And I've sometimes used the first-gen TKIs. So I've gone to erlotinib during the 3 to 6 months when I want that immunotherapy to wash out and then think about switching to the third-gen later, just because of this.
And actually, to switch to a slightly different point, one of the differences in toxicity is the cardiac toxicity. Even though osimertinib doesn't have a very high QTc prolongation or reduced ejection fraction, it occasionally happens, and lazertinib does appear to have a lower QTc prolongation rate. So I've switched for that purpose.
Yep, we've done that too. There's definitely patients with the cardiac toxicity, and that is a useful indication. I think on this NCCN guidelines, it does say lazertinib alone. You can use it. Useful in certain circumstances, and that's one of them.
All right, for time, I'm going to jump in now for TROP2 targeted antibody-drug conjugates. So datopotamab deruxtecan, an antibody-drug conjugate with TROP2 antibody. I think at this point, people are probably pretty familiar with this. We've been talking about it for a while. Approval in both lung and breast cancer has a deruxtecan payload, which is a very potent topoisomerase inhibitor payload. This is a combination of the TROPION-Lung01 and TROPION-Lung05 studies where we looked at specifically the EGFR-Mutant cohort. And within both trials, TROPION-Lung01 was a randomized trial, all of non-small cell lung cancer versus docetaxel. It included those with actionable genomic alterations. In those individuals, they had to have gotten at least one prior targeted therapy, as well as platinum-based therapy to then be eligible for the trial. TROPION-Lung05 was a single-arm study of just individuals with tumors with actionable genomic alterations, and same criteria as I just described. Now, when looking at the EGFR pool, this was 117 patients, and this is what on the right there gives you a bit more about the EGFR cohort in particular that I've just described. So it included patients with tumors with various different EGFR mutations, and then on the table there, you can see the TROPION-Lung01 and 05 cohorts, each individually, and then the combined. Now, as far as efficacy signal, we saw a median PFS of 5.8 months within this group, about 23% of patients with a year or longer of disease control. The median overall survival, 15.6 months, 65-ish% of patients alive at a year. On the left side, you can see the median duration of response listed there as well. But response rates above 40% in this line of therapy, which a standard of care at this point would be docetaxel prior to datopotamab deruxtecan. So I'd say a response rate in the 40s% really stacks up quite favorably. Now, the toxicity profile Dr. Goldberg will get into that further, but just to point out, stomatitis and ocular surface events and ILD are each things to be monitoring for with datopotamab deruxtecan. I will just point out one thing, and I know Dr. Goldberg will get into the management of these, but just the mucositis. Mucositis is common with datopotamab deruxtecan, but grade 1 is asymptomatic, essentially. So it's really about a third of patients that end up with symptomatic mucositis. Now, that's not nothing. That still means that this is commonly occurring, but it's not the majority of patients. The 36% grade 1 is a decent group of patients that are essentially asymptomatic. And so I think sometimes the expectations about mucositis are maybe a little overstated in how frequently. That's not to take away from the importance of management of this, though. As far as CNS efficacy, we've seen this surprised me, frankly, to see CNS efficacy from an antibody-drug conjugate. We are now seeing this from multiple, and so ADCs, it looks like some of them do cross blood-brain barrier. Here on the left side there, you see the CNS PFS percent based upon dato and docetaxel. You see clear separation from those. On the right side there, now remember, TROPION-Lung01 was all comers. This is all of non-small cell lung cancer. So the squamous cohort, we didn't really see benefit from dato-DXd systemically, so we don't expect to see that intracranially. The non-squamous cohort there on the forest plot includes patients with tumors without actionable genomic alterations as well. And we see a hazard ratio of 0.37. On the bottom there is EGFR mutation absent or present. And so with EGFR mutation present, hazard ratio there of 0.33. So not huge numbers, but I'd say directionally very encouraging signal. This was CNS by BICR in those that had brain mets that had not previously been treated or had progression after prior radiation. And so we see 38% response rate as compared to 0 in the docetaxel group. So again, comparing very favorably. On the bottom there, the disease control rate within the CNS, also very high at 88%. Waterfall plot just shows you this further. The stars are those with tumors with EGFR mutations, just further highlighting the responses. And spider plot also showing some of the durability that we see in this as well. Now, dato-DXd, of course, was granted approval by the FDA last year in the treatment of EGFR-mutated non-small cell lung cancer after prior targeted therapy as well as platinum-based chemotherapy. Now, TROPION-Lung14 is a phase 3 study, OSI plus minus dato-DXd as first-line therapy. So this is underway. And TROPION-Lung15 is also a phase 3 trial of dato-DXd plus minus osimertinib in those that had prior progression on osimertinib. So kind of a dato-DXd version of the COMPEL trial. There is also a platinum doublet chemo arm to this study as well. Now, sac-TMT is another TROP2 ADC that has also shown impressive results. This was from last year, and you see the waterfall plot of the overall population, and then on the bottom there is individuals with tumors with EGFR mutation. In that group, the median progression-free survival was 11 months. And then, of course, also we have last year published in the New England Journal was this specific to the EGFR population versus chemotherapy. You see that some of these patients did have T790M mutations, and not everyone had gotten a prior third-generation EGFR TKI, but many did. Although note that in the first-line setting, it was only around 60% of patients that got it, and then second-line, of course, particularly those with the T790M mutation, resistance mutation to their first-line, likely first-generation EGFR TKI. But progression-free survival of sac-TMT versus chemotherapy curves separate out quite a bit. As you can see, median progression-free survival of 8.3 versus 4.3 months. And overall survival is still, the data continues maturing, not yet reached versus 17.4 months median overall survival. Now, the toxicity of sac-TMT, I'm going to talk about briefly. And the reason I'm doing that is really to highlight across the TROP2 drugs, what is a TROP2-directed toxicity? And, of course, you see there were many patients that got dose reductions and dose interruptions, so it's not to say that there certainly is some toxicity with this drug. I think alopecia is worth calling out. Alopecia we don't really talk about enough. Alopecia is something that impacts patients. I think it impacts patients more than they want to admit. I think many feel like if they're saying it, that's somehow vanity. But for patients, when they look in the mirror and they've lost their hair, they see themselves differently, and it's a reminder to them. And I think that's worth calling out when we see it on tox profiles. Now, stomatitis is listed here as well. This table does not list ocular surface toxicity because the table is for 10% or more. But there was about 10% ocular surface events also. There was no ILD or pneumonitis with this regimen. But I'm highlighting, I think ocular surface toxicity and mucositis are both TROP2-related toxicities. And as an aside, I find it interesting, when we look at these on paper, we could put sacituzumab govitecan there too, a TROP2 antibody, topoisomerase inhibitor payload, cleavable linker. These all look the same on paper, yet we don't have these toxicities with sacituzumab govitecan. We get a lot of diarrhea, but we're not really seeing the TROP2-directed toxicities with sacituzumab govitecan, which I find interesting. But we are seeing that with sac-TMT and Dato-DXd across both of them. So with that, we can jump into more cases.
Datopotamab deruxtecan is approved in progressive EGFR-mutant disease, and Dr. Divers is managing a 74-year-old woman who received prior adjuvant chemotherapy for resected lung adenocarcinoma, but who then presented with a metastatic EGFR exon 21 L858R mutant recurrence and received chemotherapy and osimertinib, and on disease progression was treated with Dato-DXd.
She's currently on datopotamab and doing amazingly well with that. Her pain and symptoms have gone away.
How long has she been on the Dato, and does she have any tolerability issues with it?
She's really done amazing. She's completed 5 cycles of datopotamab. Her pain went away. She's had no cytopenias. She's seen the ophthalmologist, had no ocular toxicity, and had no symptoms of ILD. So it's really been an amazingly successful. We participated in some of the datopotamab studies, so we give everybody dexamethasone mouth rinse.
Dr. Apuri is considering discussing with her patient, who's determined to avoid chemotherapy and now receiving lazertinib with amivantamab, the option of an ADC as her next treatment, specifically datopotamab deruxtecan, and Dr. Apuri has a number of related questions.
When they have used it on their patients, have they seen the toxicity profile very similar to chemotherapy or better than chemotherapy? And the second thing is, have they done dose reductions upfront on individuals like her who are worried about the side effects and the quality of life? And have they achieved a durable response for those patients when they have done an upfront dose reduction? Is there anything prophylactically that they would use in these patients to reduce the risk of side effects?
Okay, so the side effects, so the mucositis, stomatitis, of course, it's recommended within the FDA label to be doing steroid mouth rinses. This is something that came from the fact that it was included in TROPION-Lung01, but it was really included at the end, so not everybody on the study got it. In fact, most of the patients had not. I still question how much these matter. I do recommend that patients get it, but let's say you have a patient that's starting Dato-DXd and they just go, I'm not going to do mouth rinses 4 times a day. Do you say, no, you have to? Or do you say, okay, well, let's see how it goes?
I believe in it. I think that UCLA, we were the ones to recommend it. I might be wrong.
You were.
But, so I found it to be really useful. I found that there are patients, you're right, not everyone, but there are significant patients that have trouble eating. Just pain in that way can be very debilitating. And the Dex mouth rinse I find to be useful. So I do recommend it. I say, why don't you start twice a day? That's my negotiation.
That's a good way to do it. Twice a day is better than nothing.
Yeah.
Yeah, we definitely built it into our order sets of the electronic ordering for the plan, so it's very easy to send out a prescription. Many of our patients with skin toxicity go and see the supportive dermato-oncologist, the cutaneous group, and some of them, like skin, is in the mouth also, and we'll send them over. And their biggest suggestion was definitely do the Dex mouth rinses and give them the 500 ml bottle, not the 250 ml bottle. Like, they need more; they're using a lot of it. The eye toxicity I haven't seen as badly. Like, it's really not been an issue for me. And instead of sending people to an ophthalmologist, which, at our institution can take a month or 2 or 3, we actually just say, go check in with your optometrist to make sure you get a baseline exam so that you can make sure nothing changes.
Yeah. So how about before I move on, I totally agree. And also the ocular surface toxicity, I have not seen someone where it was like an emergent thing. If you see someone with vision changes, with beefy red eye, these are ophthalmologic emergencies that may not even be from the Dato-DXd. So if that kind of thing is going on, they need to see ophthalmo immediately. But for the most part, although I refer people, I would never hold someone's start up for waiting for an eye exam. And similarly, if someone starts developing symptoms, usually it's kind of similar to pemetrexed in what they get. I'm not saying that the cause is the same. There's a lot for us to still learn. But that kind of like eye scratchiness or tearing or irritation, and so using preservative-free eye drops is essentially what they start, and then get in with ophthalmology. But as far as the sequencing now, so we've gone through first line, we've gone through second line now with Dato-DXd. Piece together for us, what is I realize there are outliers, I realize there's patient discussion, but I'm really going to push you to say, broadly speaking, here is the path I follow.
I think as complicated as first line is, second line is even more complicated. That there are some relatively easy cases where the patient's been off chemo for a while, just been on OC, and then going to chemo amivantamab is a very appealing adjustment. But many patients that go directly from chemo OC, I'm a little bit unsure where to go. I have used Dato-DXd. They have gotten both the TKI and the chemotherapy. And I think the data is compelling. It will be helpful to have that filled out in a randomized trial. But that's what I've done. The other direction I think is also hard, but after Ami-Laz, going to a chemo-based regimen, often with osimertinib, based on the compel data, I think is appealing.
Yeah.
I'm a fan of all of these drugs. I think there's good activity for some patients. All of them. You just heard about a case where the patient did really well with Dato-DXd. My preference is that I try to give patients chemotherapy, carbopem, and amivantamab before they get Dato-DXd. What order that is complicated. It depends what you start with. But I try to get it all in before they get Dato-DXd. So if someone starts with chemo OC, I might give them Ami-Laz second line and then Dato-DXd. So I try, even though Ami-Laz is not approved for second line, it's something that I will sometimes do. That's how I think about it. I think one of the questions asked in the video was about the tolerability of Dato-DXd, and I think it is good, but I think it's similar to carbopem. I don't think it's so much better that we should be moving it ahead of carbopem. So if someone hasn't gotten chemotherapy, I would tend to do that first.
Yeah. Now, you said that you sometimes use Ami-Laz after OSI chemo.
Yes. I don't know why I said sometimes.
Do you
often.
typically?
Yes.
You often do. Okay.
It's a regimen that you get the amivantamab in, and if they are just coming off chemotherapy, I don't want to give them more chemotherapy, even though the approved regimen is chemo-ami. If they've been off chemotherapy for a while, I think that's reasonable to do. But there's data for Ami-Laz in previously treated patients. And so it's not approved that way, but it's something that I commonly will reach for if someone has recently gotten chemo or they didn't do well with chemo or can't get it again.
So speaking of Chrysalis 2, Dr. Passaro, there was a question here that in Chrysalis 2 seemed to be an interesting observation regarding MET-positive IHC patients as a probable positive predictive factor for amivantamab. What happened with the exploratory analysis of MET-IHC in the Mariposa trial?
Yeah, we had the first part of data that supported for patients with a high MET expression immunochemistry that was a very, very strong signal at the present time. We have only data of MET amplification in liquid biopsies that do not support the stratification according to the MET. So this is not to discuss that amivantamab are not a MET inhibitors. It's a bispecific antibody, so there are different kind of signals that could be related to the MET pathway, but data also updated by Benjamin Bess on the MET expression did not identify a strong signal to stratify patients according to this biomarker.
Okay. A couple that I'm going to pair together here is, let's see, is there a role for using ctDNA in deciding when to stop pemetrexed in the maintenance therapy? This, of course, with FLAURA2. Stop pemetrexed in maintenance therapy with OSI, or dose intensification of adding pemetrexed to OSI, so the Shedders trial, if ctDNA is positive. Well, let's do that one, because that's a couple questions in one.
I think there's all these different risk factors that we talk about that should lean us towards using a combination therapy. But ctDNA positivity is a pretty strong one. And so I think that following that is a reasonable way to better understand your patient. We all discussed that we do at this time like to start with combination therapy. But if there's some reason, post-operative patient or a patient with another health issue going on at the same time that you start osimertinib, I think re-risk stratifying after a few months would be a reasonable data-driven approach.
So here's a tough one. Patient with 2 de novo EGFR mutations on tissue NGS, 1 exon 20, but 1 rare EGFR exon 19, known to be sensitive to osimertinib. How would you proceed?
I don't know that I can answer that exact one, but I think we do sometimes see these double EGFR mutants, right? It happens.
Yeah.
And so some of them are, a lot of times you'll see these rare ones together, so 2 uncommon mutations together. I often just need to look them up because I think there are some data out there. There's been a few studies looking at uncommon EGFR mutations, and I think it's helpful to see which ones have been shown to have sensitivity to the third generation TKIs and which are resistant. So there are some papers out there where you can look these rare mutations up and rare combination mutations up and see if there's any data for them. So I don't know that you can say blanket statement.
Well, broadly, if there's an exon 20...
I guess if there's an exon 20, those tend to be resistant, right? Anything in exon 20 tends to be resistant. So then that's probably right. That may be someone that a TKI is not going to work for. But just in general, I think those uncommon mutations, you need to see what they are and what they may be sensitive to. Because they really shouldn't be lumped together just because they're rare, right? They are just very different.
It may be the 768I that they're referring to, which my understanding is it doesn't have a big impact. So I think that if you have an exon 19 deletion, which I heard was rare but is sensitive, I think a typical regimen would be reasonable. And I do think that's probably some of our comfort and support for a combination regimen. I think we're seeing less primary resistance, which wasn't common but was very disheartening when it happened with single-agent TKI.
One quick comment about, there was another page of discussion there, is that just dose reduction of datopotamab deruxtecan, I don't worry about too much. In the phase 1 study at the 4 mg per kg dose level, we saw a pretty good efficacy signal. So if someone's having mucositis that really they need a dose reduction, I don't worry about dose reduction so much. Yes, go ahead.
That was the one point I wanted to add about the Dato-DXd is I'll often continue the TKI together with it. So I'll often continue the osimertinib. I just wanted to kind of see whether other people are doing that too, because as you pointed out, there is a clinical trial ongoing. We have a little bit of safety data. There may be more side effects, but I'm nervous about not doing with OC, so we're not exactly following the package label. Others?
Noted.
I agree with you. I think we've now seen multiple studies where continuing the TKI is beneficial. So I also give the combination, even though that's not the way it's approved.
And I think especially in that case that we heard, a patient who's actually second line, considering the osimertinib with Dato-DXd was also, I wrote it down on my note card.
Yeah, I fully support. So all the trials, positive or negative, maintain the TKI, showed better results of the control arm without the TKI. Also in the Mariposa 2, in the arm with lazertinib, the ORCHA trial, the Savannah maintaining the TKI. So the message is very, very strong, supported by the biology, that maintaining the inhibition with the TKI could be beneficial for patients.
All right, with that, Dr. Goldman will speak on emerging role of bispecific antibody-based approaches for EGFR-mutated non-small cell lung cancer.
Thank you. I have the fun pleasure of talking about what's coming on the horizon. It's hard to know which of these will come through, but we may get data and results and information in the next months and year about some new agents for us. So we're first going to begin by taking a little step back and talking about immune therapy and why it's been generally challenging in EGFR mutants. The introduction of a bispecific immunotherapy VEGF drug, ivonescimab, and the Harmony data. Isobren as another bispecific, and talk about how that is a different mechanism, also promising. So back in the early days of immunotherapy, we were all quite excited. Patients would fly across the country to get pembrolizumab. In Los Angeles, we see a lot of EGFR patients. And it turns out that EGFR patients untreated often have a high PD-L1, which may go down on TKI therapy. So we had this idea that should we start with pembrolizumab before a TKI? We treated 10, 11 patients, and it was actually very quickly a dismal result. Their only response ended up being rechecked and was not EGFR-mutated, in fact. There was a death due to early pneumonitis once they started a TKI. So this became very clear to us that first-line monotherapy immunotherapy for EGFR mutants, regardless of PD-L1, was not recommended. What were some of the other possibilities? Since that, following now, we had more results from the pivotal immunotherapy trials, OAK, Checkmate 057, Keynote 010, et cetera, that included some EGFR patients. At the top, you see the main take-home message that these were all very positive trials beating docetaxel. But at the bottom is the EGFR cohort, and no strong suggestion of benefit, and several of the trials end up suggesting harm from immunotherapy monotherapy. How about adding in chemoimmunotherapy? A meta-analysis in JAMA showed across the board poor benefit from a chemoimmunotherapy approach, and these three trials were the main support of that. Keynote 789 with pembrolizumab, Checkmate 722 with nivolumab. Orient 31 is a little complicated, so I'll start with just the sintilimab arm with chemotherapy. With sintilimab, there was a PFS signal, but OS, no difference. Why is that? I think we probably don't know all of the answer, but I think there's two basic answers. One of them is the low tumor mutation burden. We've all talked about this being a marker in immunotherapy prediction. I don't think it's a very good predictor for a single patient, but for understanding a tumor across the board, I think it is actually instructive. Most of the highly responsive tumors are high mutation burden. We also do know that EGFR does induce some signaling that is immunosuppressive. It disrupts helper T cells. It decreases interferon gamma, which is the main pathway through which cytotoxic T cells lead to tumor cell death. It upregulates TGF-beta. This is the PD-L1 data. Probably hard to see, but for the two left columns are EGFR wild type and EGFR mutated. The red are the low, green are intermediate, and blue are high. So you can see the EGFR mutants are a little bit lower in the PD-L1 expression, but not major differences. One thing that does stand out that I'll just point out from a different talk, you might say, is regarding MET. MET is often quite high with PD-L1, ROS1 too. But this is what I wanted to focus on. This is tumor mutation burden. Again, a lot of data here. This is a log scale, so small differences are meaningful. And you can see that EGFR wild type has meaningful more TMB, tumor mutation burden, than EGFR mutants. And if you go down the line there, it actually does correlate with our experience. Some of these, like HER2, BRAF, those are tumors that are oncogene driven, but we still think immunotherapy probably has a role. Those are tumor types with higher TMB. Now, though we talked about immunotherapy being challenging in EGFR patients, how can we crack that nut? How can we make these tumors more responsive? And one of the early solutions was adding atezolizumab and bevacizumab to chemotherapy. This was going back a while now, but the concept behind the Empower 150 trial. I think VEGF is still also somewhat of a mystery, but a lot of it is normalization of vasculature, lowering tumor pressure, and allowing chemotherapy, other medications, but also T cells to traffic into the tumor. There are also VEGF immunologic interplay that does decrease the tumor microenvironment, immunosuppression, and probably is playing a meaningful synergistic role with chemotherapy. We now have these two trials that show that adding in the IO to chemo VEGF does improve outcomes. So the Empower 150 on the left, this was a subset analysis of the EGFR mutants. This was a post hoc analysis that were not included in the primary endpoint. So I don't think this can be fully considered fully practice changing, did not lead to FDA approval. But when they looked at all the EGFR mutants, the hazard ratio was 0.60, really quite impressive. Those that had received prior TKI, which is really the time that we're looking at this type of approach, hazard ratio not quite as good, but 0.74. I also mentioned before, Orient 31 was a little complicated. There was a sintilimab, a PD-1 inhibitor, but also a sintilimab with VEGF antibody. With chemotherapy. And if you go from chemo to chemo VEGF to chemo VEGF-IO, you have that, actually I misspoke, chemo-IO, chemo-IO VEGF. You do have an increase in PFS with each of those additions. However, the overall survival curves are overlapping, so neither of these trials became truly practice-changing, although I have used Empower 150 at times. This is where the first new drug I wanted to talk about comes in. Ivonescimab, a PD-1 VEGF bispecific antibody. One end is VEGF, the other end is anti-PD-1. And just like we talked about with Empower 150, but in the same drug, which may be meaningfully different, this drug may really localize to the tumor microenvironment where it can have both of these anti-angiogenic and immunotherapy benefits. So this trial, I realize I'm going to speed up a little bit and feel free to look at my slides afterwards. This trial was randomized 1-to-1 for patients that had progressed on a EGFR TKI. They received ivonescimab chemotherapy or placebo chemotherapy, double-blind trial. The trial enrollment was a little complicated, began in China, and then later was expanded elsewhere. They combined the Chinese patients that had first-line, third-gen TKI to the rest of the world, Europe and North America, third-gen TKI, and analyzed them together. However, a little heads up, the issue is that, of course, they have different follow-ups because the ex-China group was enrolled later. So this is the PFS by independent review. The curves separate, they stay separated. I would say this looks like a little bit more than a VEGF benefit, but challenging perhaps to say. Hazard ratio of 0.52 and more than a 2-month PFS benefit. Overall survival benefit just barely missed significance on its preset final analysis. 2.8 months difference in overall survival. We'll go through the side effects in a minute, but generally well tolerated and very close to a p-value with further follow-up, including more follow-up in the North American and European group that nominally went below 0.05. Subgroup analysis shows generally consistent benefit, although many trials have shown, interestingly, that L858R, I think I circle it at the bottom, right there, L858R does often in immunotherapy trials do better than exon 19 deletion. There are some good HLA-based explanations for why that may be true, while why L858R could be better presented to the immune system. I think Sarah may also be going through some of this toxicity, but this is the overall toxicity analysis. And I think in general, the two arms experience somewhat similar toxicity rates. However, when you focus on immune-related adverse events and VEGF-related adverse events, you obviously see differences. Immune-related, mostly hypothyroidism. There was, I think, a couple cases of ILD, but low grade, so not particularly clinically significant. VEGF, there definitely were some more grade 3 toxicities, but mostly hypertension, proteinuria, grade 3 bleeding events were very low. Oh, and I'm now out of time, but I wanted to tell you about this other very exciting drug, isolantamab, which also has a topoisomerase inhibitor payload. What I think we may be seeing more and more of these bispecific ADCs. The appeal, I think, is quite significant. By looking for two antigens on the tumor, you'll increase your specificity to the tumor and decrease your off-target effects. So hopefully more efficacy, less toxicity. And in summary, I think that is supported. This drug does have some really exciting development in other tumors, but I'll focus on lung cancer with EGFR mutations. This was a combination from the phase 1 and 2 trials. The response rate, disease control rate were all very impressive. Waterfall plot meaningful. In the spider plot, some of those responses are extending out to a year and a half. I have a patient who's now been on this for a couple years with really excellent benefit. Adverse events were a little bit more on the chemo-like hematologic toxicities, but mostly asymptomatic toxicities. So getting to my conclusions, EGFR-Mutant non-small cell lung cancer has an immunosuppressive phenotype. If we want to bring immunotherapy benefits, we do have to look for new combinations and new drugs. Ivonescimab, we'll probably learn later this year if it will be an option for us. And bispecific antibody-drug conjugates, especially Isobren, I think may be an exciting future.
All right, and we'll jump into a case again by Dr. Divers.
Dr. Divers has another real-world issue. A 67-year-old woman with EGFR-mutant metastatic disease responding well to the FLAR2 regimen when she was diagnosed with a second primary cancer.
This is a lady who presented with malignant pleural effusion with hydropneumothorax, and biopsy showed exon 21 EGFR mutation. She was treated with carboplatin, pemetrexed, and osimertinib and had a really nice response. But on subsequent restaging studies, we found a lesion in her colon that was a biopsy-proven adenocarcinoma. Can you guys comment on what would the expected duration of disease control, especially now taking into account we have a datopotamab in the second-line setting, and would you consider offering this person adjuvant chemotherapy for her stage 3 adenocarcinoma of the colon, understanding she has an unresectable incurable lung cancer? She did have 2 positive nodes, and so would qualify for adjuvant chemotherapy. We normally would never consider that in a non-small cell lung cancer patient with incurable disease. But, for some of these EGFR patients, they do well for quite an extended period of time. And so oxaliplatin and a 5-FU-based regimen would be the recommended standard, but given her weight loss and some diarrhea from the osimertinib, that may be a bit difficult for her to stomach.
So what are you thinking here?
I'm a fan of the ctDNA. I actually ordered a Signatera ctDNA to be drawn when she comes back. And if it's negative, then I would lean against offering her. If it was positive, then usually those patients do recur, and I would consider that.
So I'm assuming he's talking about ctDNA for the colon cancer, right? But what this is raising now, someone with an EGFR mutant lung cancer, without getting into the specifics of the colon cancer, a colon cancer where you would typically give adjuvant therapy. It is carboplatin and
Folfox.
Folfox.
Yeah.
Oh,
I think
okay.
it said Folfox.
So 5-FU and oxaliplatin. Okay, 5-FU and oxaliplatin regimen with the osimertinib. Well, essentially, what is your expectation about duration of disease control and risk of a colon cancer? What do you think?
No, please go ahead.
I'm assuming we're going to say similar things. Well, I'll just start. So, it's very hard to predict, of course, any one individual person, how they're going to do on their EGFR therapy. But we saw the data from those 2 first-line trials where the median PFS was over 2 years, the median OS was 4-ish years. And that's median. So we know some of these patients are going to do very well for a long time. Not knowing as much about colon cancer, I think that needs a really thoughtful conversation with if there's another treating physician, or really thinking about what is the benefit of the chemotherapy for colon cancer in that setting, because this is not a curable cancer, but this patient could live for several years. And then there's a toxicity overlap from all of that, because you don't really want to stop the TKI. I think it's probably fine to pause the pemetrexed. I think it's a tough conversation, but this patient could live for several years. So if it's a high-risk cancer, an adjuvant chemotherapy could help. I think it's really amazingly reasonable to consider. But otherwise, I think if it's a trivial benefit, skip it.
So unfortunately, this is not that rare a case. I've got several breast cancer patients. I've got a couple ovarian cancer patients. And sometimes there's a convenient combination. Someone's getting carbotaxol for ovarian cancer and osimertinib for her lung cancer. But in this case, there's a real challenge, and I think a lot of overlapping toxicity concerns with the GI issues. I think that Sarah raises all the right points, that understanding the risk of recurrence, but I think it's approximately 40% colon cancer recurrence risk, and adjuvant chemotherapy does lower that meaningfully. So it's challenging, and it's challenging to talk to a patient about their survival 2 years from now and how that may impact the treatment that we do. But a lot of times I've found that the breast cancer patients say, in this case, I don't want to take an aromatase inhibitor, for example. And I think there's a lot of different ways to balance these issues.
Yeah, I've seen a number of patients with concurrent malignancies, too. I think one of my patients just got a GIST removed. I had a patient with bladder cancer who got adjuvant therapy with bladder cancer with the osimertinib on board. So it's perfectly doable. I think Folfox and osimertinib should be compatible. I'd drop the pemetrexed, of course, but I wouldn't exclude it as a treatment option. I had a patient who had colon cancer removed 7 years ago in the setting of EGFR-Mutant stage 4 lung cancer and is still on osimertinib like 7 years later, right? So you don't know how they're going to do.
Yeah, I think
right? So you shouldn't exclude the option of adjuvant chemo. The privilege at an academic institution is I don't have to make this decision. I'm going to refer them to GI oncology.
Yeah, but I share that. What I am careful to do is not remove the best case scenario option. So if you have someone who may end up with many years of disease control, I don't want to limit what happens later on. Now, whether or not they should get adjuvant therapy is a risk-benefit balance to discuss with GI, but I've, in small cell lung cancer, I've had someone where I continued tarlatamab, where they got chemoradiation for their rectal cancer, and that was a year ago, and she's doing well. So, this is, I think, a scenario where I agree. I think considering getting treatment, if it's really indicated, don't lose the best option. Dr. Passaro, I'm going to ask you this one. There's a question about, is it absolutely necessary to continue pemetrexed with amivantamab after 4 cycles of carboplatin pemetrexed and AMI, or is AMI maintenance an option? Where is your line to where you can stop the pemetrexed?
Discussing in Mariposa 2.
Yes.
Okay. So I share my experience. So in my site, we participated in Mariposa 2, and now we have 6 patients ongoing after 3 years with amivantamab monotherapy. So it's not very small signal because in one site, the 6 patient is very, very high. And generally, the patient receive 6, 7, 10 cycle of chemotherapy. That is very, very huge number. Consider the median in the Paramount that is 4 cycle pemetrexed. So I think that is important to guarantee at least the 4 cycle of platinum pemetrexed, a median number of pemetrexed monotherapy, so 5, 3, 4. And then the benefit, I think, is related to the efficacy of amivantamab. So consider that the median PFS is 6 points. I think that we can consider to stop pemetrexed after, 5, 6 months of treatment. Okay. But this is my opinion. It's not related to the combination trial.
Dr. Goldberg has the hardest job now because she's going to take us through the toxicities after all of this discussion as well, kind of weaving together the last part of the risk-benefit balance.
I don't know if it's the hardest job because you all set the stage so well. So I'm going to be talking about, as you've heard through this whole program, the tolerability considerations with all of these therapies you just heard so much about. And there's not that many programs like this where this is really such an important conversation, but it really is when we have so many different options and different treatments. The tolerability and what we can do to prevent issues and treat issues is so critical. So here's what I'm going to focus on is first looking at these first-line options that you just heard about, OC chemo and Ami-Laz. That's really, of course, an important consideration there is the toxicity profiles that are so different. And then, as you've heard, we've talked a lot already about how we can reduce toxicity from amivantamab. I'll go through some of those studies and the data that we have. We'll talk about Dato-DXd a bit more, and then briefly about ivonescimab. So this is looking at the comparison of FLAURA2 and Mariposa, looking at the data from the published studies, again in first line. And so we already discussed a lot of this. I won't go into the detail because you already heard it. But just in general, on the top, what you can see in FLAURA2, hopefully you could see it. I can't see it at all. But what I know is on this slide is that the toxicity from FLAURA2 is what you would expect. It's many chemotherapy toxicities. We all know carboplatin, pemetrexed very well. On the left in that figure, what I'm showing you there is the adjustments that were made for osimertinib and for pemetrexed. So comparing patients who got chemo OC to OC alone, there was a little bit more dose reductions and discontinuations of the OC in the OC chemo arm of the study than there were in patients who got OC alone. So, of course, that tall blue bar there on the right are patients who require discontinuation of pemetrexed. So that's more than 50% of patients eventually discontinued pemetrexed. But even in FLAURA2, osimertinib required dose reductions or discontinuations because of toxicity. So that's something to consider for these patients. Mariposa is a totally different regimen, right? That's where you get the EGFR-related toxicities, some MET-related toxicities, but it's really the skin toxicities, the paronychia that comes into play with these patients. In Mariposa, this was before we really were giving VTE prophylaxis, so you can see here that VTE was a common occurrence in patients on Ami-Laz, much higher than in patients who got osimertinib alone. That, I'll show you in a few minutes, was greatly reduced when we started using VTE prophylaxis. But because of these toxicities that we see with Ami-Laz, many patients required dose reductions and many also required dose discontinuations of the amivantamab. So something to keep in mind that was done on both of these trials is the dose adjustments and the the treatment discontinuations in order to continue these patients on the TKI. So what has been done since those first trials to try to improve the toxicity with amivantamab? And this could be used with amivantamab regardless of if you're using it in first line or in second line or later on. So this was the SKIPPR trial. This was trying to reduce the risk of infusion-related reactions. I didn't even mention that when I was talking about amivantamab. But this was really a huge issue with Mariposa that many, many patients were having infusion reactions. And SKIPPR basically looked at how we could reduce that risk with different regimens of dexamethasone. And so this was the regimen that came out of this study. It was oral dexamethasone, 8 milligrams given for a few days before and then on the day of the amivantamab. And it actually worked very well to reduce the risk of infusion reactions, and you can see that there. Probably not so relevant anymore because of this. This was the study you heard about earlier, Paloma-3, which compared subcutaneous to intravenous amivantamab. And this did the trick, right? This really nearly eliminated the risk of severe infusion reactions and really overall administration-related reactions. You can see it's about 13% with the subcutaneous form and really no high-grade toxicity. And all those other bars there are really all the different symptoms related to the infusion reactions, all of which are lower with subcutaneous form. So this now, for me, has become standard practice. If I'm starting someone on amivantamab, I'm giving them subcutaneous. I'm actually starting to switch my patients over from IV to subcutaneous, mainly because of the time toxicity, right? Once patients get through the first cycle of amivantamab IV, they don't really have this risk anymore, but I'm often switching them over because it's a much faster treatment. It's just 5 minutes with some monitoring afterwards, as opposed to several hours for the IV form. So Cocoon was another really important trial trying to improve outcomes in terms of tolerability for patients receiving amivantamab and lazertinib. And so really this was looking at using enhanced dermatologic prophylaxis. So Cocoon, this is the regimen here. In case you aren't familiar with it, patients received oral antibiotics for the first 12 weeks, and then they received topical antibiotics after that. They also received chlorhexidine for their nails, and then and then moisturizer. I couldn't see what was on the bottom. And moisturizer for their skin. This study also included VTE prophylaxis, and it also included the skipper regimen. Again, not so relevant now that we have subcutaneous amivantamab. But it tried to put in these different types of prophylaxis to make the regimen more tolerable. And it worked. You can see the frequency of grade 2 or greater skin toxicities was much reduced with the use of these prophylactic regimens, but it still occurs. So you can see the rates go down, the rate of higher grade toxicity goes down, but still is present for many of these patients. The thing that didn't change so much was paronychia. It went down to some degree, but it wasn't statistically significant, and we still see it quite a bit with this regimen. But across the board, whether it was scalp, face or body skin toxicity, all of those were reduced with this regimen. So this is something that I think you can hear from the panel, but I think most of us are using now when we're starting a patient on amivantamab. Again, whether it's with lazertinib or in combination with chemotherapy, we're giving the Cocoon regimen as well as VTE prophylaxis to reduce the risk of all of these toxicities. So that leads us to Copernicus. So Copernicus was a trial to try to put all of this together. We have different pieces of data for amivantamab prophylaxis and management, toxicity management, and Copernicus was trying to put that all together in the first-line setting because a lot of these other studies were in later lines. And so Copernicus is for patients with previously untreated EGFR-mutant lung cancer. There were two different cohorts. One was for, the cohort 1 was for previously untreated. Cohort 2 was for previously treated. Cohort 1 was Ami-Laz. It was sub-Q Ami every 4 weeks. Cohort 2 was with Ami chemotherapy after prior osimertinib. And it was, again, trying to put all the prophylaxis in place. So for cohort 1, this is data that we are presenting at ASCO on Sunday. There's a poster that's there. Come by and I'll say hi. This is the data that was in the abstract, so it's not the full data that will be presented. But basically what this showed was that using the Cocoon regimen and using VTE prophylaxis really seemed to help in the first-line regimen. And so what the table shows you here is Mariposa data. So this is not a randomized study, but the Mariposa data and then the Copernicus data. And you can see the rates are much better on Copernicus. Therapy discontinuations due to AEs were 34% on Mariposa, 5% on Copernicus. Administration-related reactions went way down, only 9% with the sub-Q form. Rash went down to 22% from 62%. Paronychia was also better, and then VTE was only 7%. So much better when you're using all of these strategies. And then similarly for cohort 2, this was a much smaller cohort, only 29 patients. This was the Ami chemo after OC. This also looked like the toxicity was much better. It's there in the text in that second paragraph. The skin, the rash, and the paronychia occurred in less patients when compared to Mariposa 2. And efficacy also looked similar. Okay, so that was talking about amivantamab. Now briefly talking about Dato-DXd. Again, you already heard a lot about this from Dr. Sands. You heard about how stomatitis and nausea were common, alopecia as well. You also see cytopenias to some degree, and then there's the incidence of ILD or pneumonitis in some patients as well, a few patients who had high-grade toxicity. Overall, this is the TROPION-Lung01. So this is not EGFR specific, but 20% of patients on Dato-DXd required dose reduction and 8% required treatment discontinuation. When you look at patients specifically with EGFR-mutant lung cancer, the data look very similar in terms of toxicity. We see mucositis or stomatitis, we see the ocular surface events, and in small numbers, but still real, we see ILD and pneumonitis. We briefly mentioned earlier in our discussion about the ORCHARD trial. This was Dato-DXd plus osimertinib. This is looking at 2 different dose levels. The one that's going ahead in those other trials that were mentioned is the 6 milligram per kilogram dose of Dato-DXd with osimertinib, so the standard dose. Looking at the different doses and looking across the trials, it does look like the rate of stomatitis and ILD might be higher with the combination. So when we're using this off-label, it's definitely something to keep in mind, not to treat patients who you're worried about with this combination, especially without prospective data in a randomized trial. What can we do for this? Well, there's a lot that we try. We try oral dexamethasone rinses, as you heard. I do try it. I didn't mention on the panel, but I do try to have my patients do this when possible. Flossing, good dental hygiene in general. Cryotherapy is something that we do try in our clinic, giving, they can drink ice water or suck on ice cubes or ice pops while they're getting their infusions. I think 2 and 3 are probably really the most important. Watching these patients closely and having a really low threshold to think about pausing treatments and dose reducing, I think that's absolutely critical, as you heard. ILD, same thing. I think we really keep a close eye on these patients. I showed you there is this risk of ILD, even high-grade ILD, although it's low. Monitoring these patients and having a really low threshold to pause treatment while you're evaluating for what's going on when you see a scan, even grade 1, is something that's really critical. And then lastly, I'll talk about ivonescimab, just again very briefly, because you already saw this. You heard that this is a bispecific antibody that is an immune therapy as well as a VEGF inhibitor. So the toxicities you get, of course, relate to both of those. But I think overall, this does look like a very well-tolerated drug, understanding that you could get these different IRAEs as well as VEGF blockade-related toxicities. But I actually wanted to mention something that we didn't really talk about before with ivonescimab that I find difficult about immune therapy in general in these patients, which is this. So to me, the biggest risk with giving ivonescimab or any other immune therapy is that you have to stop the EGFR inhibitor, and it's very hard to go back to it. So if you need to go back to it, if someone's progressing and you want to restart the TKI, that's really the risk we talked about before, that overlap, and that lasts for several months, even with ivonescimab. So really something to think about if we're going to start to give more immune therapy to these patients is we're going to have to stop the TKIs and the risk of cancer progression with that. And I will stop there. Thank you very much.
We'll jump into another case.
One of the most challenging aspects of the use of targeted treatment is the decision to reduce the dose because of toxicity. Dr. Divers is managing a 75-year-old woman with EGFR exon 21 L858R mutant metastatic disease with an interesting disease complication that resolved with osimertinib, which also required dose reduction for GI toxicity.
This lady initially presented back in 2018, and at that time, there really wasn't great adjuvant data, and her tumor was less than 4 centimeters. So she was followed conservatively. She did develop a rising CEA, which we were watching, did a workup for malignancies, and she developed a Paget's disease in the perianal soft tissue. We biopsied repeatedly. There was never any invasive component. It was felt to be perineoplastic. So we subsequently repeated her scans and did bronchoscopy and an endobronchial ultrasound, got a biopsy of a subcoronal node that confirmed recurrent adenocarcinoma of the lung. We attempted to do NGS on her Paget's, and there was never any invasion. So it's not a metastasis as much as a perineoplastic event. We placed her on osimertinib, and her CEA declined to normal. Her Paget's disease resolved, and subsequent PET-CT scan showed a response. But she did have quite a bit of diarrhea related to the osimertinib and requested dose reductions. Are you comfortable with dose reductions to 40 milligram if they're unable to tolerate it, or what schedule would you recommend there?
All right. What do you think?
It's a cool case. I think we're publishing a patient who had hyperthyroidism due to an elevated beta HCG, not due to immunotherapy, just due to her tumor. So there are these really rare paraneoplastic conditions, and sometimes they get better when you treat the underlying malignancy. And for the question, I think dose reduction is totally reasonable. I do try to manage diarrhea with loperamide, but sometimes patients say they're unwilling to leave the house because of diarrhea, and that's really, I think, an intolerable situation. So I think dose reduction usually resolves the toxicity quite meaningfully.
Yeah, diarrhea can be really disabling for people that just stay at home. I find more commonly I end up reducing osimertinib for fatigue, just especially older, more petite individuals where sometimes, nodding, what are your thoughts on dose reductions and whether it be diarrhea or anything else?
Yeah, luckily it's rare that you need to. Most patients are able to tolerate the full dose. I just showed that, single digits on FLAURA 2 that needed dose reductions, but it happens. And I think those are the two things really I've seen too, fatigue and diarrhea. I have done 80 alternating with 40. I don't know if anybody else has done that. Someone who's really worried about going to 40, I'll do every other day. I made that up. I don't know if anybody's tried it. It seems fine. But I think it's fine to go to 40 milligrams. I think this, when people have these toxicities that are really quality of life impairing, I think 40 milligrams is very reasonable.
Yeah.
I would say in my experience, more often, it's not obvious that it's clearly from the osimertinib, but it's after a while that they've been on the drug and they're just complaining about a bunch of things like tiredness and low appetite and all this other stuff. And I'm like, let's figure out if it's from the drug. So I'll give them a week or two off, no problem, just to see if whatever they're complaining about clears up. The classic dose hold, right? Before you decide to do a dose reduction to make sure that it is probably attributable. And then when I come back in, I'm like, you can take a pill on Monday, a pill on Thursday. You could take it Monday, Wednesday, Friday. Ease yourself back into it and see what the comfortable dose is for you. And I don't usually go to the 40 milligrams unless somebody's kind of on an every other day schedule, because the half-life is so long that every other day dosing is actually approximating the 40 daily. So I haven't messed with two different pill strengths. I would probably do instead, I do hey, Monday, Wednesday, Friday, plus or minus Saturday.
Right. I do like the holding drug for a few days just to get clarity. I think so often we're dealing with decisions on probabilities, and so anything I can do to provide clarity to the decision making.
And I'll offer, some of the patients I'm hold for a week or two, and they're I'm fine. I actually don't feel that good. Then you can tell that it's tolerable, not intolerable, right? That's the test.
That's true too. That does come up. Dr. Passaro, the last question there, introduction of subcutaneous administration and various prophylactic measures for amivantamab. I mean, clearly this has made it more tolerable. So I'm going to ask you a variation of this is more, how much more tolerable? I mean, how much better do you think the tolerability is, the tox profile, relative to what we've seen from the initial data?
So, in my opinion, it's a complete other story. So, as discussed by Sarah, so the implication of a Cocoon, Skipper, Copernicus, so is a whole program of improvement today modify completely the feelings about the toxicity profile of amivantamab. So, and we are discussing here the opportunity to have a longer-term exposure to amivantamab, and all the data now are supporting this. In the other way, amivantamab IV is not an easy drug. This, of course, the first month is very, very invasive for all the patients. And also the other toxicity without Cocoon, more than Copernicus, are very difficult to manage for a long-term exposure, in particular pyronic and scalp reaction. But for example, scalp reaction with the correct support in the Cocoon now is a very easy toxicity to manage. And this is why I think we need to implement more for the understanding of pyronicia that, in my opinion, today is the open question for amivantamab.
Well, We're at time. There are some more questions. Thank you to everyone for submitting questions. It's hard to get to all of them. There's so much to discuss. Thank you to the oncologists that submitted cases. These were wonderful cases to discuss. And there's so much more of those cases that we could discuss. Have a wonderful ASCO.